In reviewing the general trauma care protocol, one of the highlights is that we have a new protocol that combines abdominal injuries, chest injuries, impaled objects, and shock all into one protocol, which provides a general approach to the trauma patient. So we're going to touch on some of the newer things that are being shown through that. One of the things, of course, is the issue of impaled objects. It reminds everybody, of course, to not remove impaled objects, to, of course, stabilize them. That is what we've always done. But again, if it's in the chest, leave it where it is and do CPR around it, stabilize it, and don't remove it. Pelvic fractures should be stabilized. Now, this, of course, brings up the issue as with what? The protocol is silent on that. However, commercially available pelvic stabilization devices are probably the best thing. Otherwise, you could certainly use sheets. For paramedics, again, reminds us to perform needle decompression, obtain intravascular access, and cardiac monitoring during trauma care. Paramedics, of course, can still administer crystalloid fluids, 20 milliliters per kilogram IV. Again, remembering to not overload the patient with fluids, as that can be deleterious to a bleeding patient. Pain management is discussed now in a separate protocol, but we should treat pain as needed and indicated. Some key points to remember. Of course, decreased breath sounds, muffled heart sounds indicate life-threatening chest injuries, and transportation in the most expeditious manner is, of course, indicated. The first priority for trauma patients is to stop further external bleeding, something we all know. Crystalloids, of course, as we mentioned, temporizing measures for patients in shock from blood loss. Don't delay transport. Nothing in this protocol should indicate that we're going to do that. Don't delay to get intravascular access or administer crystalloids. In traumatic cardiac arrest for both the adult and pediatric patient, paramedics, of course, should transition from the AED to monitor, look for shockable rhythms as per AHA guidelines if, in fact, we suspect that the arrest has a medical cause as opposed to a traumatic cause. We all have had cases in which, for example, someone had a heart attack and then crashed their car. If it's indicated, run the protocol for the medical condition while transporting expeditiously for trauma care. Medical control options will give us the option to run additional fluids in cases where it may be indicated and necessary.
A new protocol that has been added to the trauma section is for an avosed tooth for both the adult and pediatric. Prior to reviewing the protocol, I would like to spend a few minutes reviewing the anatomy of the mouth and the teeth in order to make sure that you understand how this protocol will work. So first of all, we're looking at the mouth, and the areas that are indicated are the different areas of the tissue that could be affected with a facial injury with an avosed tooth. So it's very important to realize that if there's significant damage to either the alveolar mucosa or the vestibular area or the free gingiva, then there may not be an opportunity to reimplant this tooth. When we look at the avosed tooth area, the important area that we're going to be dealing with is the alveolar bone. If there is significant damage to the alveolar bone, then it may be impossible as well to replace the tooth, as there is too much damage for the tooth to be reimplanted with a successful outcome. looking at the tooth itself, it's very important that when you're handling the tooth, as you'll see with the protocol, that you're only going to be handling the tooth from the crown area, which is the top area of the tooth. Connected to the crown is the neck, and then you have the roots. It is very important not to touch the neck or the roots, as you may cause significant damage and cause, again, the reimplantation to not be successful. So let's take a look at the actual new protocol. First, as in any patient that we deal with, we're going to check our patient's ABCs and vital signs, as they are the most important when we're treating our patient. If our ABCs are stable and their vital signs are within normal limits, then we can turn our attention to the avulsed tooth. Make sure, again, as I mentioned, that you hold the tooth by the crown and not the root. Quickly rinse the tooth with saline before reimplantation, but be very sure not to brush off or clean the tooth of any tissue. So it's simply taking a little bit of saline, pouring it over the tooth, and then doing the reimplantation. When it comes to looking at the mouth, you're going to remove any clots from the socket. You're going to suction the clots if necessary. And then you're going to reimplant the tooth firmly into the socket with digital pressure. Once done, take a piece of gauze, put it on top of the tooth, and have the patient hold the tooth, hold the gauze and the tooth in place, and using gentle bite pressure. Report to the hospital staff upon arrival that the tooth has been reimplanted, and make sure that obviously we transport the patient in position of comfort. In terms of key points, the best transportation medium for an avulsed tooth is in its socket, in an appropriate situation. The best chance for success is when we reimplant this tooth within 5 minutes of the injury. So it should be of highest priority, except for obviously our ABCs and unstable vitals. There are some big do nots. So for example, if the patient has altered mental status, we do not want to reimplant it because we run the risk of aspiration if the tooth doesn't stay where it's supposed to be once it's reimplanted. We also don't want to reimplant the tooth if the patient has to be transported supinely for the same reason. We do not want to reimplant the tooth if there is missing alveolar bone or gingiva, or if the root is fractured. And finally, do not reimplant if the patient is immunosuppressed or reports that they have cardiac issues, that they have to take antibiotics prior to having any type of dental procedures. Remember that if the patient is not a candidate for reimplantation and you have an avulsed permanent tooth, place the avulsed tooth in an interim storage medium. So either a commercial tooth preservation media, low-fat milk, patient saliva, or saline in some type of a container, and keep it cool. Try to avoid tap water storage if possible, but the key point is do not allow the permanent tooth to dry out. Now I'd like to show you a video on how the process will take place.
Welcome to the EMS protocol update for the avulsed tooth reimplantation protocol. My name is Jeremy Cushman, and as the Regional EMS Medical Director, I will take this opportunity to review with you this new protocol. The first question you must be asking is, why do we have a protocol on how to reimplant avulsed teeth? Well, the length of time before a tooth is implanted and how it is transported are crucial in successfully saving and reimplanting the permanent tooth. In fact, the best chance for success is when reimplantation occurs less than 5 minutes from injury. As you will see, this is a simple procedure that any level EMT can perform in the field. The criteria for reimplanting a tooth within the protocol states to only reimplant permanent teeth. So how can we tell? Baby teeth include 10 on each jaw for 20 total. As you can see on the left figure, the front teeth start appearing at approximately 7 to 8 months of age, while the rear teeth appear closer to 2 years of age. Baby teeth are replaced by adult teeth, and number 16 in each jaw for 32 total. As you can see in the figure on the right, on average the incisors appear between 6 and 8 years of age, and all the teeth are permanent by about 11 or 12 years of age, with the exception of the third molars. Knowing when these teeth appear is important. For example, a 5-year-old is unlikely to have permanent front incisors, while a 10-year-old is likely to have permanent front incisors. For those that are between 5 and 10 years of age, there are some other ways to tell permanent teeth from baby teeth. First, there are small protrusions located on the top of permanent teeth called mamelons. These are very noticeable when the permanent teeth first erupt, and they will wear off in time with use. Secondly, baby teeth are very white in color, whereas permanent teeth look a bit more amber or yellowish in color. This is perfectly normal. In this slide, which are the permanent teeth? That's right, the white arrows point to the permanent teeth, which are slightly yellower and have mamelons, compared to the black arrows that point to the smooth, white baby teeth. Now try this one. Which are the permanent teeth? That's right, the white arrows point to the permanent teeth, which are slightly yellower and have mamelons, compared to the black arrows that point to the smooth, white baby teeth. The protocol also indicates that we should not reimplant if the alveolar bone or gingiva are missing or if the root is fractured. So how do I tell that? These two images demonstrate significant damage and maceration of the gingiva. The figure on the upper left in particular is suggestive of alveolar bone fractures as well. These two images demonstrate fractured teeth. The one on the left is still in place, while the one on the right represents an impacted tooth. In both these cases, nothing should be done in the pre-hospital environment to manage them. All of these images represent teeth that should not be reimplanted. The two upper pictures demonstrate posterior displacement of the teeth. Although they are not avulsed, they are often associated with fracture of the underlying bone and should not be manipulated. The lower image again demonstrates significant maceration of the gingiva, precluding safe reimplantation. All of these photos, however, represent the location of an avulsed tooth that is eligible for reimplantation. As you can see, it is often the central incisor that is avulsed, and this makes for a relatively simple reimplantation. So let's review our criteria one more time. We should only reimplant permanent teeth. Our best chance for success is when reimplantation occurs less than 5 minutes from injury. We should not reimplant if the alveolar bone or gingiva are missing or if the root is fractured. We should not reimplant if the patient is immunosuppressed or reports having cardiac issues that require antibiotics prior to procedures. We should not reimplant if the patient requires spinal immobilization, as there is a concern that the tooth could become dislodged during transport and aspirated by the supine patient. Similarly, someone with an altered mental status should not have the tooth reimplanted, as they may not be able to maintain their airway. If the patient is not a candidate for reimplantation, you may place the tooth in interim storage media, which could be low-fat milk, the patient's own saliva, or saline, and keep cool. When possible, avoid tap water, but at the same time do not allow the permanent tooth to dry. To reimplant the tooth, hold it by the crown. Quickly rinse the tooth with saline before reimplantation, but do not brush off or clean the tooth of tissue. If necessary, rinse and suction any blood or blood clot from the socket. Reimplant the tooth firmly into the socket using digital pressure. Have the patient hold the tooth in place using gauze. Depending on the tooth, leaving the gauze in place and having the patient apply bite pressure will also hold it in place. Transport to any emergency department, and when you arrive, report to hospital staff the efforts made to reimplant the tooth.
Hemorrhage control and bleeding, not much terribly different. Again, we assess the site of injury, control external bleeding accordingly. There are numerous protocols on that, some of which will be covered in the BLS section of this protocol review. For uncontrolled junctional bleeds, pack the wound with gauze or hemostatic dressings, put a pressure dressing over the area, and secure in place. For all levels of provider when controlling hemorrhage, remember, for severe external bleeding, pressure dressings, hemostatic dressings, and wound packing are all things we will continue to do. If severe bleeding persists with conventional dressings, remove them and use hemostatic dressings.
So for burns, not many changes have been put into place, but we do want to make sure that the protocol flows correctly, which is that we're on the CFR and the BLS level, maintain that patient's body temperature. With our medics, we're going to still continue cardiac monitoring, and we're for full partial thickness burns, second degree burns or higher. Anything greater than 20%, we do want to administer the crystalloid fluids, and note that it is weight-based, so 20 milliliters per kilogram via the IV route with a maximum of 1 liter. Under the medical control options, if your transport is delayed, again, weight-based, 20 milliliters per kilogram bolus, and we're gonna do an additional 1 liter. This change was put into place due to patients being fluid overloaded being brought to the burn center. So please make note of that. Some key considerations are other injuries, including cardiac dysrhythmias. Don't forget them. Make sure you assess for them. And most burn patients do not need aggressive pre-hospital fluid resuscitation.
Chemical eye injuries, we have 2 options, proparacaine and tetracaine, and both can be repeated as needed. For bone and joint injuries, the one thing that's changed is that the procedures for pain management have been moved to the general pain management adult and pediatric protocol. So if you need to control pain, you'll find the options in that other protocol. In cases of carbon monoxide poisoning, we continue to transport rapidly to the nearest hyperbaric center. Paramedic level care will include airway management, cardiac monitoring, including 12 lead EKG, and obtaining IV access. In smoke inhalation cases, obtaining the patient's CO level is important. Paramedics, again, advanced airway procedures, cardiac monitoring, IV access, and treat for cyanide poisoning as needed by referring to the cyanide poisoning adult and pediatric protocol. Treatment for cyanide poisoning should be based on the following criteria. Critical patients with potential cyanide exposure. If at a WMD scene, of course, a class order is required. Class orders may be issued by FDNY OMA on scene, online medical control, or FDNY EMS dispatch, as in the past. Treatment within the hot and warm zone should only be performed by appropriately trained providers wearing the appropriate protective gear as determined by the incident commander. If providers encounter a patient who has not been decontaminated, leave the area until decontamination has been performed. No significant changes beyond that. These criteria should be familiar to anybody who's been reviewing the protocols. The Weapons of Mass Destruction protocol contains a number of charts. We recognize that not everyone is going to be looking at these charts all the time, and that there's a lot of information in them. So rather than review every single point on them, you should remember that the treatment of weapons of mass destruction occurs after a class order has been issued, and you can and should refer to the following charts, which will guide you in terms of what to do. Various types of agents that we will encounter during a WMD incident. These protocols apply to both adult and pediatric patients. And again, look over the charts, understand what they are, and we understand that you're probably going to be looking at them during the event rather than memorizing all of them right after this protocol review. However, if this is the only time you're looking at them, you're not going to remember what to do. So do familiarize yourself with what we have here. if you're following along with the protocols. Recognize that some of the doses have been updated and familiarize yourself with them. In a WMD incident, the FDNY OMA response physician may order additional dosing of any of the standing order medications that were found on the previous charts. Remember the key points in evaluating nerve agent exposures as part of the WMD protocol. Sludgem refers to salivation, lacrimation, urination, defecation, GI distress or upset, emesis or meiosis. All of these things should be things that you look for in a potential nerve agent exposure. Remember that in nerve agent exposure, key goal is to dry out secretions. Diazepam remains the drug of choice to control nerve agent-induced seizures. Do not administer more than 3 nerve agent antidote kits to any patient. And asymptomatic patients, regardless of what's going on around them, do not require treatment. Make note of all treatments given, including the number of doses on the triage tag. Patients whose skin or clothing are contaminated can put you at risk by off-gassing. So hopefully you're wearing the appropriate PPE. Patients who have ingested nerve agents may off-gas dangerous levels of vapor, including from vomit, even after they've been deconned on the scene. Something to keep in mind.